Hello everyone. We now have two sets of VOP on gastrointestinal pharmacology, 1 and 2, and this is number 1, and as usual my reference is Goodman and Gilman Book of Pharmacology. What is the outline? What you see here is the outline of both VOPs, VOP1 and VOP2. In this one we will cover this section, and the next VOP we will cover this section. What we will do here, first we will start with a description of the physiology of emesis, emesis being vomiting, but we will also talk about nausea, and then we will discuss antiemetic drugs. After that, we will also briefly describe the physiology of intestinal motility, basically the peristalsis and the neurology behind it, and then we will discuss some prokinetic drugs. So let's get started with the physiology of emesis. So now that we're going to talk about the physiology of emesis, this figure may look complex, but it's okay. We're going to explain it also slowly, and you will see that there is a lot of overlap between each center. First, I'd like to differentiate emesis from nausea. So emesis is actually vomiting. So you actually have a contraction of your bowel upward so that one vomits. Whereas nausea is the bad feeling that you want to vomit, but it's not the actual vomiting. So emesis is the vomiting, whereas nausea is the feeling that there will be emesis. Now, since we made this differentiation, where does anticipatory nausea work, or what does it affect? For instance, one can think of something that you don't like, or maybe you fear or you dread something, or you anticipate that somebody is going to bring you something that you don't like the smell or whatever. So just the thinking about it will stimulate the higher centers in the brain, and that will lead to the activation of the emetic center in the medulla. And then you would vomit, obviously. So the emetic center is the place where it triggers emesis, and sometimes anticipatory nausea, only anticipation of a bad smell, a bad food, bad whatever, or a bad thought, right, will stimulate the higher centers and ultimately lead to emesis because of stimulation of the emetic center. Fine. Now, how about other factors that will lead to stimulation of the emetic center other than thinking? Let's go over those one by one, and you will see that again there is some overlap. So let's start with the pharynx, or the gagging reflex. So this is upward. So if you eat something and it bothers you, you gag and then you vomit. And this is good. This is a protective mechanism, right? You don't want to eat something that bothers you. And how does this work? So the gagging actually leads to activation of the glossopharyngeal and the trigeminal afferents, and this will lead to activation of the solitary tract nucleus in the brainstem. And what receptors are involved here? The serotonin receptors, D2, dopamine receptors, and we're going to talk about them a little bit later when we talk about therapy, but you will see the dopamine receptors later in the psychiatry module when you talk about antipsychotics, and I will explain that in a few slides from here. Muscarinic receptors, H1, histamine receptors, and K1 and cannabinoid receptor. So remember those receptors because actually we're going to target each one of them to prevent emesis. Fine. What else other than the gagging? There are two things that might affect the stomach or the small intestine, and that would be activation of the serotonin receptors, 5-hydroxytryptamine. That could happen either from local irritants or from blood-borne emetics. What I mean by local irritants, you take something and it bothers the stomach or the small intestine. That could be cytotoxic drugs. We took cytotoxic drugs together, the drugs for cancer therapy, and some of them are given orally, and they might irritate the GI tract. At times, people give copper sulfate as to treat, to lead to emesis. For example, if somebody got intoxicated by certain drugs, you really want to induce emesis so that the person vomits, so that all the drugs that he or she took gets out of the system. Now, usually what we do is actually the serum of Apopac, and I will tell you about it in a minute. Other factors that might lead to local irritation of the stomach and small intestine could be radiation. If a person receives radiation therapy for cancer, for instance, that would lead to irritation. Of course, obviously, bacterial infection and viral infection that will lead to enteritis with nausea and vomiting. How about the blood-borne emetics, meaning that this comes from the blood? There are the cytotoxic drugs that we take by IV, and other drugs that may lead to blood-borne emesis. Opioids, cholinomimetic, obviously, some specific drugs that are notorious for being emetic, cardiac glycosides, L-Dopa, bromocriptine, apomorphine, not for your memory, those are just examples of many. And here, the syrup of Ipecac, this is the one that we use now in the emergency room to induce emesis in somebody who comes and intoxicated with a lot of drugs, etc. So in here we have activation of 5-hydroxytryptamine, and then what next? What next is that we have vagal and sympathetic afferents that lead to, again, activation of the solitary tract nucleus through the receptors that we talked about before. But also at the same time, this will lead to activation of the chemoreceptor trigger zone, or the area prostrema. So it can either happen directly from the blood-borne emetics, or through the stomach it goes and then it goes back to the area prostrema. This is a very important area. This is, we call it, if you want, a defense mechanism or a monitor. It's really here to protect us, human beings, from toxic compounds. And look where it is located. It's not located in the CNS, it's located here by the blood-brain barrier, so that actually whatever is toxic would reach it. You don't want it here protected with the blood-brain barrier. You want it to be reachable so that it monitors if we are exposed to toxic compounds. It's a defense mechanism again. And what is activated in this area? Similar receptors, 5-HT3, D2, M1, and the cannabinoid receptor. And ultimately, again, this is leading to activation of the emetic center, or through the solitary tract nucleus all the way again to the emetic center. Fine, so we've done this area, What else? Sometimes we have some sensory input that will lead us to vomit. We may smell something we don't like. We may see something we don't like. Maybe we are in too much pain and we may vomit. And in this case, the activation is in the higher centers of the brain. And finally, the last thing I want to mention is this area here, the inner ear. If the inner ear is activated because of motion or because of drugs, aminoglycosides, you've seen those before when we took the antimicrobials, well, this will lead to activation of H1 and M in the cerebellum, and again, excuse me, leading to activation of the emetic center, and we have emesis. What is that here? This is motion sickness. For example, there are some people who go in a boat and they cannot tolerate being rocked in the boat all the time, and they may vomit. Or sometimes in the airplane, but definitely in the boat much more. And sometimes we have to preempt this. Sometimes we have to give antihistamine or anticholinergic so that we prevent this motion sickness. And you will see that as well in the future slides. All right, so in this slide, there are a few information that we already talked about. that we've seen in the figure before. Again, it's very important to differentiate emesis from nausea. Nausea is anticipatory, it is thinking about it, and it will lead to vomiting, whereas emesis is vomiting itself. We discussed how much it's a complex, coordinated phenomenon in the central nervous system, and this will lead to ultimately backward propulsion of the gastric content. We talked about the differentiation between the higher brain centers versus the chemoreceptor trigger zone, that is before the blood-brain barrier as a mechanism for protection. We already discussed nausea, how different it is from emesis, and the sensation of nausea being at the higher brain centers. Something that we haven't really mentioned, we talked about cytotoxic drugs, we talked about chemotherapy. Some of them are associated with acute vomiting, some are associated with delayed vomiting, and also most of them are associated with anticipatory nausea and vomiting. What do I mean here? You know, if a patient has cancer and has already received chemotherapy or cytotoxic therapy and developed very bad nausea and vomiting in the first cycle, when the patient comes back to the hospital 21 days later to receive chemotherapy again, well, the patient may anticipate nausea, may remember the bad nausea and vomiting that he or she had, and they might have nausea and vomiting even before receiving chemotherapy. This is why you will see with some of the antiemetics that we may give some that are long-acting, or some that we may give them preemptively before the nausea and vomiting happens. So again, you will see the antiemetic drugs in the coming slides. Some of them are more effective against acute emesis, others are maybe useful for delayed emesis. Delayed emesis is harder to treat. I will not explain and differentiate the mechanisms of both because it is complex, but I will point out one thing in the upcoming slides. So here we go. Let's start with the antiemetic drugs. And this is the outline that we will follow. And I think if you look at the mechanism of action of each class, it will really make sense to you after having seen the physiology of emesis. So we already talked about serotonin, we talked about dopamine, we talked about cannabinoid, we talked about NK1, we talked about H1, and we talked about the muscarinic system. And hence, you can guess now that antiemetic classes would be following those mechanisms, being antagonist or agonist on the cannabinoid receptor. The drugs that we will talk about are listed here. For instance, ondansetron as serotonin receptor antagonist. I will be talking about others, but ondansetron is the classic one if you want. The dopamine receptor antagonist, we'll be talking about metoclopramide, promethazine, and I will be talking about others as well. Same here, dronabinol, nabilon, aprepitant, and others, as you will see, cyclizine and scopolamine. Okay, now if you look here at the most effective against category, so those category of classes of drugs are mainly good for cytotoxic drug-induced emesis. Now, if you remember with me, where are those? Where could you find those? Well, you find them in two areas: the solitary nucleus and the chemoreceptor trigger zone, and the cytotoxic drugs, both being the irritative ones in the stomach or the blood ones, will ultimately activate those two centers. Now, how about the neurokinin receptor antagonists? Well, the NK1, if you remember, they are only in the solitary nucleus. And this is one of the reasons why those would work for delayed vomiting, because they would have to pass through all those pathways. Again, this is a complex differentiation, delayed versus acute, but this is one of the explanations. Also, for H1 and the muscarinic receptor antagonist, I think you can guess by now that this would work for vestibular emesis, because if you remember the motion sickness and the aminoglycosides, what is happening here? We have H1 and muscarinic receptor activation. Okay, so this is the outline, and we're going to go through it like this with some additional names, some peculiarities, as you will see in the next slides. So let's start with the H3 antagonist. I don't know if you ever heard of the drug Zofran. Anyone who knows anyone who had cancer and received cytotoxic chemotherapy must have heard of ondansetron or Zofran. Why? Because this is a really very potent anti-emetic drug that is very good against chemotherapy induced nausea and vomiting, and also post-op nausea and vomiting. At times when we wake up from surgery and from anesthesia, we are nauseated, sometimes we vomit, and Zofran would also work. And this is ondansetron, which is the prototype. Obviously there are others with similar mechanism of action. Now, palonosetron is a more recent molecule. It has a higher receptor affinity, longer half-life, so it will stay in the blood for a longer time, and sometimes we need that, especially for patients who receive chemotherapy. Where does this work? I think you know this by now from the figure that we saw together. We talked about the area postremia, or the chemoreceptor trigger zone. We talked about the solitary tract neurons, and later in this VOP, actually we will talk about the motility of the GI tract, and we will specifically talk about the vagal afferents and the GI serotonin receptors. So they also work on that side as well. Therapeutic uses, they are very effective for chemotherapy-induced nausea and vomiting, and that also works after GI tract irradiation. Remember when we talked about irritating the stomach or the intestine? Well, those receptors will be triggered as well. They can also work for pregnant women. We talked about post-op nausea and vomiting. I do not expect them to work for motion sickness, because what are the mechanisms in the motion sickness? H1, muscarinic. Palonosetron, the one that has a longer half-life, it stays more in the body, so it would work for delayed nausea and vomiting. You can guess that. Now you would tell me, so why are you telling me that this can be found as oral drugs, oral disintegrating tablets, IV or IM? Why is this important? Well, remember, those patients are nauseated and vomiting. If you give them this drug as PO, maybe they will simply vomit it. Maybe they will not tolerate it. So at times you need to give those drugs as IV and IM so that they do not vomit them. Also, for the same reason, granisetron, also in the same classes of drugs, is available as a transdermal patch. You can give it as 7 days. So if somebody has very severe nausea and vomiting post-chemotherapy, you don't want to give them PO drugs all the time, you can prescribe the patch, and that will prevent nausea and vomiting. So how about adverse effects? Those are usually well tolerated, but they could be associated with headache, lightheadedness, constipation, and or diarrhea. Fine, but what I want to focus on are those two highlighted in red, the QT prolongation and serotonin syndrome. QT prolongation is a big deal because this may lead to arrhythmias. You will understand more that when you take cardiology next year. And when could that happen? That is specifically problematic if the patient is taking other drugs that may also cause QT prolongation. And we took some together in the antimicrobials. For instance, I believe I should have mentioned that with the fluoroquinolones and the macrolides. Also, remember, those patients are having nausea and vomiting, so they may lose electrolytes. So they may have electrolyte imbalances, abnormal level of sodium, abnormal level of potassium, and those would also contribute to QT prolongation, and hence one has to be careful with those drugs. Another thing that I want to point out is serotonin syndrome. Now let me warn you that serotonin 5-HT binds to different types of 5-HT receptors. So now we're talking about the 5-HT3 antagonism, right? But there are 5-HT1 and there are 5-HT4 and 5-HT5. The story is much more complex, and those are distributed in different places in the body, some in the brain, some in the GI tract, and also some of them function differently. Why am I saying that? You will understand better the 5-HT receptors when, again, you take psychiatry, and Dr. Sabra will talk about the mechanism and their role in depression. Fine, but for our level today, I'm going to mention the SSRI, such as Prozac, Seroxat. Those are selective serotonin reuptake inhibitors. So they inhibit the reuptake of serotonin so that you would have high levels of serotonin. And when we have too much serotonin, this leads to serotonin syndrome that you will study in psychiatry. It's basically some neurologic manifestations, among others. So in here, although we are blocking 5-HT3, by blockage of 5-HT3, you would have serotonin that is more available in the blood to work on other receptors, such as 5-HT1, among others, and that would lead to serotonin syndrome. So I hope I didn't confuse you much to trying to explain the mechanism of serotonin syndrome potentially happening if you take those 5-HT3 inhibitors with SSRIs. Now we're done with the HT3 receptor antagonist. Now how about the dopamine receptor antagonist? What receptors are we blocking here? We're blocking the D2 receptors. Where are those? Those are in both the chemoreceptor trigger zone as well as the solitary nucleus, but they mainly reach the chemoreceptor trigger zone and hence preventing further excitation. Those commonly used drugs are chlorpheniramine and chlorpromazine, and we can also use phenothiazines in adults and children. Okay, those drugs, the drugs that block the D2 receptors, such as those and others, specifically the phenothiazines, you will also see them in psychiatry, and they are used to treat psychosis actually. Okay, but in here obviously we're not treating psychosis. We are using the blocking of the D2 at the CTZ to prevent emesis. Fine, so now you tell me, why are you talking about them as used in psychosis? Because one, when you see them in psychiatry, you will see them a little bit more. You will know that they are not specific to blockage of D2 receptors. They can also be antihistaminic and anticholinergic. So they may be useful a little bit in motion sickness. This is one. And okay, fine, they can be given IV, IM as a suppository. Why is that important? Because your patient is nauseated and vomiting. You want to have alternative routes. But let me go back to being the phenothiazines, this class of dopamine receptor antagonists. They are also associated with extrapyramidal side effects. Also, you will take that in psychiatry in Med2, but one of the extrapyramidal side effects is Parkinsonism. So Parkinson, you probably know patients with Parkinson. This is a neurodegenerative disease where we have a problem with the substantia nigra, for instance, in the brain, and hence we have decreased production of dopamine. So we have low dopamine, and this is why patients have this Parkinsonism. In this case, it's a side effect of the drug. We are blocking the D2 receptor, and hence we are having extrapyramidal side effects such as Parkinsonism. So you will see those with those antiemetics. So that's not a joke to take those medications. In addition to that, we have the risk of QT prolongation and hypotension. Finally, in the elderly, sometimes elderly present with psychosis. Again, you will learn what psychosis is in psychiatry, but if I want to tell you something about psychosis, it's that somebody has an abnormal thinking. Someone is not really in this world. Someone has hallucinations, someone is lost in time, etc. And we can see psychosis in schizophrenia, for example, but you can also see psychosis in the elderly. In the elderly, it will not be schizophrenia, because schizophrenia does not present in the elderly. It presents in young people. In this case, it is dementia-related psychosis, neurodegenerative disease. And also sometimes elderly have delirium, and that is when they come to the hospital, they get lost. They're not used to the hospital. They don't know where they are. They don't know who those people are around them, and they get psychotic. And we have to treat psychosis in the elderly. However, those drugs, we do not want to give them to the elderly because they become the higher rate of dying from those drugs. So I told you a lot of information, but if I want to summarize, what is this slide about? This slide is about the dopamine receptor antagonists, the phenothiazines. We have those drugs as examples. And in addition to D2 blockage, we also have histamine and cholinergic blockage. And don't forget about the extrapyramidal symptoms. Now, the D2 receptor antagonists that we talked about in the previous slide, we call them the typical antipsychotics. Remember, I told you that those drugs are actually antipsychotics against psychosis, and you will see them in psychiatry to treat psychosis. And we call them the typical, or the first generation. Now, because they had so many side effects, you will learn that we also have the second generation, or the atypical antipsychotics, that not only block dopamine, they also block HT2 receptors. Okay, we like those because they do not lead to extrapyramidal side effects as much as the first generation typical antipsychotics. They are used off-label for the prevention of chemotherapy-induced delayed nausea or vomiting. And what do I mean by off-label? Well, in the drug development lecture, I talked a lot about the label, the FDA label, for example, the piece of paper that gives all the information about this drug, what are the pharmacokinetics, the pharmacodynamics, what are the indication of this drug. So they tell you, if you open the label of olanzapine, the indication is for psychosis, but you can give it for nausea and vomiting, although you do not find this in the label. And it's okay, it's all right, as long as the drug is approved for something, you can use it for something else, as long as you know what you are doing. Also used for refractory, non-chemotherapy induced nausea and vomiting, although we are happy that it does not lead to much extrapyramidal side effects, and this is why they are second generation. They are associated with side effects, some CNS depression, hypotension, QT prolongation, and most importantly, metabolic and endocrine side effects, basically hyperlipidemia and diabetes, as a matter of fact, and weight gain. And those side effects, you do not usually see them much with the typical antipsychotics or the D2 antagonists. Finally, metoclopramide or pramperon. This is also a D2 antagonist, but it's a different structure. It is not a phenothiazines like the typical antipsychotics. It's not like olanzapine, the atypical antipsychotic, different structure. And you will see it again later in this VOP because it's also used as a prokinetic. When we talk about that, you will see it. It's not that effective against acute chemotherapy-induced nausea and vomiting, might be used for delayed nausea and vomiting. And it's also used for GI motor disturbances, again, prokinetic effect. We will see that later. You might have heard of pramperon before. So if I want to summarize in a nutshell, if you are faced with a patient who is receiving chemotherapy and that person has mild nausea and vomiting, you may give Pramperon. But then if it's really, really bad, you're gonna go to Zofran, the first class that we talked about. Next are the cannabinoid receptor agonists in this case, and the typical drugs are dronabinol and nabilon. What do? They stimulate the cannabinoid receptor 1, where in the chemoreceptor trigger zone and emetic center. And those drugs are highly lipid soluble, well absorbed, fine. They are not really first line. You don't want to give cannabinoid agonists as a first line treatment for nausea and vomiting. We have alternatives, right? We already discussed alternatives, and we have others that we will discuss. However, sometimes we can do that, and we like them really in patients with anorexia or AIDS to stimulate appetite. This is an advantage that we can make use of. There is the potential for drug-drug interaction, and most importantly are that we have tons of complex CNS side effects. This is why we don't like them. We have central sympathomimetic activity, palpitation and tachycardia. We have cardiovascular effects. We have, of course, obviously the marijuana-like highs. So the patient may become euphoric, somnolence, detached, anxious, and what you are really afraid of is the serious paranoid reaction. Paranoid meaning that you are very scared, you are apprehensive all the time, and this may precipitate psychosis, so we really have to be careful. You don't give those drugs and just ignore. Obviously, you would have withdrawal symptoms, and by the way, you are going to take those drugs in psychiatry again, but once you stop them, the patient may have withdrawal symptoms, may become irritable, cannot sleep, and restless. In conclusion, you really want to be careful with those drugs, and definitely you have to be super careful in somebody with a history of substance abuse, because you would have a risk of more substance abuse. Now, next are the neurokinin receptor antagonists, the NK1 receptor blockers, the receptors for substance P. In here, they are mainly effective against delayed chemotherapy, and we talked about that when we were in the slide of the outline. And the typical drugs are aprepitant and fosaprepitant. This one is given orally, this one is given injectable, and you know by now why this is important. And we also have rolapitant as a very highly selective drug with a very long half. Next are the antihistaminic drugs, and we already talked about them, that they block H1 receptors, specifically in the vestibular efferents and the brainstem. This is what is important to us right now, and hence we already mentioned them, that they are very useful in motion sickness. Remember, if we go on a boat, or if we take aminoglycosides, for instance. But they can also be useful in post-op nausea and vomiting. Why is that? Because so we saw the H1 receptor in the solitary nucleus, for instance. What are those drugs? Cyclizine, meclizine, promethazine, and diphenhydramine is the drug that you will see mostly used for motion sickness. The problem with blockage of H1 is sedation. And why is that a problem? So imagine yourself going on a trip, on a boat trip, for instance, and you're bothered by the motion sickness, so you take an H1 receptor blocker, but at the same time you would be sedated. So I don't think it's going to be a nice vacation if you are sedated on the boat all the time. All of them have some degree of cholinergic blockade. So one has to be aware of the side effects and contraindications. You took that into autonomic nervous system. And some contraindication could be, for example, elderly with glaucoma, elderly with prostate hypertrophy. And this is most prominent with cyclizine. And this can be used as adjuvant therapy in gastric cancer, where it can help to prevent emesis, among others. Anticholinergic drugs, we were expecting to have this slide. And the typical drug that we use for motion sickness is scopolamine, and I put the box here because I thought it's very interesting, with the boat, with the plane, with the car, and with the train. It is also available as a transdermal preparation, so if you're going on a long trip, you can just put the patch and you will be all right. And again, you have to be careful about sedation. You may ruin your vacation if you are sleepy all the time. Finally, some miscellaneous antiemetics, glucocorticoids. We will talk about them, I think, next year when we talk about asthma, the mechanism of action, etc. We mentioned them briefly in cancer, if I remember well. And in cancer, we said we use them to gain weight, to be happier. They have an anti-cancer effect, and they also have an anti-emetic effect. Benzodiazepine, those activate central GABA receptors. You will take those in psychiatry. Examples are lorazepam and diazepam, Valium, for instance. And what do those work for? They work for anticipatory nausea. Remember, we said anticipatory nausea is in the brain, is high up. It is thinking. So if I have taken chemotherapy before and I had really bad vomiting and I come back to the hospital 21 days later to come back for my next cycle, I'm going to anticipate this happening to me. It's gonna make me very anxious. So I could take benzodiazepines to calm down so that I don't anticipate this nausea, and that can work. And finally, another miscellaneous antiemetic is a combination, doxylamine succinate and pyridoxine, which is an antihistamine with vitamin B6. And this is a nice combination taken at bedtime, used for nausea and vomiting of pregnancy. Great, so we are done with the physiology of emesis and antiemetics, and now let's move to the physiology of intestinal motility, after which we're going to talk about the prokinetics.
So we have several layers in the intestinal wall. Obviously, we have two types of muscles. We have the longitudinal muscle and the circular muscle. And what is important to us here are the set of nerves, or the enteric nervous system. And for the enteric nervous system, we like to differentiate the myenteric plexus and the submucosal plexus. The myenteric plexus is mainly involved in contraction of the intestinal wall, whereas the submucosal plexus is mainly involved in the secretory function of the intestinal wall. Note that both are part of the autonomic nervous system, however, they are able to function independently as well. Now we want to differentiate the types of intestinal motility. We have two types, the myogenic, or we also call it the pendular movement, and the nerve-mediated movement. The difference is that the myogenic pendular movement is always there. It is nerve independent, and because it is nerve independent, it cannot be blocked by atropine, atropine being stopping the autonomic parasympathetic system. It cannot be stopped by tetrodotoxin, and that is a sodium channel blocker, and hence it would inhibit the action potential of the nerve. So we can't stop it with atropine, we can't stop it with tetrodotoxin, and also it resumes in vitro. So if we cut off piece of intestine and we put it in a bath that has all the needed nutrients, we will still see this myogenic movement alone. Now, how about the nerve-mediated movement? We'd like to differentiate it into two. One, in the fasting state, we haven't eaten anything, we would still have a nerve-mediated movement, and the fed state. The reason why we have nerve-mediated movement in the fasting state, and that is in order to be able for the GI to get rid of the food, to clean the bowel. We don't want the food to stay there, right? And this is the migrating myoelectric complex, and this is triggered by the motilin receptors. I want you to remember motilin receptors because they will come back to us. And now how about the fed state? So when we eat, when we have food, then this bolus of food will trigger the segmental movement and the peristaltic reflex. The segmental movement being happening in the same place, and that would be helpful to mix the food with the water and the enzymes for digestion, etc. And the peristaltic reflex, and that is the forward movement of the food from the end of the stomach all the way to the large intestine. And here in the peristaltic reflex, you would have some stimulatory and some inhibitory effect. The stimulation would be up front towards the mouth, where we have contraction. So when we have contraction up front, you should have relaxation moving forward. And this is illustrated in the next slide. So as you can see here with the peristaltic reflex, of course, you already have the pendular movement, and that is baseline. And then once we eat, orally, you should have some stimulation to move the food forward, whereas anally, you would have some relaxation so that you do not have resistance.
Alright, let's see. This looks like a complex slide, but it's okay. We're going to do it slowly. And it's important really to understand the enteric neuronal organizations. What are the neurons involved? And what are the neurotransmitters? What are the receptors that are involved? Because you will see as we move forward with this lecture and the one that comes after it, that we're going to target some of those receptors in order to treat, for example, nausea and vomiting, to treat constipation, etc. Alright, so what do we see here? Those layers, we've seen them in the slide that came before. For instance, LM being the longitudinal muscle, this is the myenteric plexus, this is the circular muscle, this is the submucosa, and this is the mucosa. And we have several neurons. Let us start with the red ones, or the one whose body is red. And for instance, in this case, it's 4 and 8. What do these do? Those are the sensation neurons. Their role is to sense what's going on, and once they sense what's going on, they're going to fire to the neighboring neurons, so we have action. And what would be the action in this case? Two things: contraction or relaxation, and secretion, right? So the sensory neurons, they are mechanosensitive, meaning that they can respond to stretch. For example, you have a food bolus entering from the oral area and reaching the anal area, so that would be mechanosensitive. But also it will be activated by the type of food that is here. For instance, inorganic acids, short-chain fatty acids, glucose, etc. And also serotonin plays a role here, 5-hydroxytryptamine, and it is produced by the endocrine cells due to mucosal distortion. So the mucosa is distorted because of the food bolus. That will lead to release of serotonin, that will lead to activation of the intrinsic primary afferents, and that is the red neurons here. What happened next? Well, after that, you really want to excite the motor neurons, and here we have those and those. And note that we have two types of motor neurons that would be excited or activated by the intrinsic primary afferents. 1 and 2 here being excitatory, and 5 and 6 here being inhibitory. Why is that? I think you can guess that those should be excitatory, so that they lead to contraction, so that the food bolus is moved forward, so that you have this peristaltic wave from the oral area to the anal area, while at the same time 6 and 7 should lead to relaxation, right? And we've talked about that in the figure below. What are the factors involved? For 1 and 2, it is acetylcholine, and that is binding to smooth muscle receptors, specifically M2 and M3. I hope you remember that from the autonomic nervous system. As for tachykinase, it is NK1 and NK2. Whereas for 6 and 7, and those are the inhibitory motor neurons, they will lead to relaxation, and here we have nitric oxide, ATP, as well as vasoactive intestinal peptide that will lead to dilation, not dilation, excuse me, to relaxation. What about the yellow ones here? Well, those are interneurons. Why are they here? Because at times the intrinsic primary afferents, sometimes it activates the motor neurons directly, and at times if the motor neuron is a little bit far, it needs the interneurons, and the same applies here. We have this interneuron here, so the primary afferent may act directly on the motor neurons or through interneurons. And as you can see here, we have two different types of interneurons. The ones that will lead to activation of 1 and 2, and the ones that will lead to activation of 6 and 7. And obviously they are different because each one has a different role. This one is going to activate this group, and hence you would have contraction, whereas this one is going to activate this group, and hence you have relaxation. And this is happening through acetylcholine. Obviously here it is on the nicotinic receptors because the interaction is between two neurons rather than and not with the smooth muscle as we had here with the excitatory motor neurons. So it's definitely not on the muscarinic receptor, but rather on the nicotinic receptors, and I'm sure you remember that from the autonomic nervous system. And for this group of interneurons, it secretes ATP acting on P2 receptors. So what have we done so far? We've done the red ones, we've done the blue ones, we've done the yellow ones, and we are left with the green ones. So I said in the beginning, two things are happening. One is contraction and of course relaxation on the anal side, but also obviously we have secretions, right? We have secretions of mucosal secretions, etc. And those are the neurons that play that role, the secretomotor neurons and also vasodilator neurons. Why? It's illustrated in this one. So in here, it is acting on the blood vessel so that we have vasodilation, so that water can come in, etc. And here it is working on a mucosal gland, for instance, and that leads to mucosal secretion. And how do they work? This bunch of neurons, they do that by also producing acetylcholine as well as vasoactive intestinal peptide. Okay, so with all of this in the background, let us now talk about the prokinetic drugs. When do we need prokinetic drugs? When do we need to enhance GI motility? Well, one example could be if a patient has gastroparesis, where the stomach does not contract well. When would that happen? This could happen, for example, in patients who have diabetes for a long time and secondary autonomic neuropathy and hence gastroparesis. So you may need to help them with prokinetic drugs. Also, some drugs may lead to decreased GI motility, such as opioids, for example, and at times you may need prokinetic drugs, among other needs. When I look at this slide, probably the most important word is this, coordinated. So what I want to do with prokinetic drugs, of course I want to enhance GI motility, but I want to do it in a coordinated way. So if I go back to the slide that was just before this one, when we were talking about the motor neurons, and there's the proximal ones, the ones that are on the oral side, and the distal ones, the one on the distal side. You really want to lead to contraction proximally and dilation distally so that you have propulsion of the gastrointestinal content. So we are going to enhance the release of some excitatory neurotransmitters, but while making sure that we do not interfere with the normal physiology. How are we going to do that? So this is the list of drugs that we will cover here. We will start with the serotonin receptor agonist. Be careful, when we were talking about emesis, we needed serotonin receptor antagonists and specifically 5-HT3, right? Here we're talking about agonists but at different receptors, and we will see that in a minute. So this is why the serotonin story is a little bit complex, but it's okay. And again, we're going to talk about dopamine antagonists, specifically D2, and we already mentioned that in the beginning, that those can be used as antiemetics but also as prokinetics. And finally, we'll talk about macrolides. Well, those are the antimicrobials that we've seen together, and they can also be used as prokinetics, as we will see in the coming few slides. So let's start with the serotonin receptor agonists. So we talked about serotonin actually in the very first neurons that we talked about, the sensory one, those that stimulate the submucosal intrinsic afferent neurons, and those that will ultimately stimulate the motor neurons and the secretory neurons, right? So serotonin actually exists throughout the body, but a lot of it is in the GI tract. And here we come back to the issue that I want a coordinated change in the GI motility. Remember, we said we could have excitatory inhibitory. What is happening here with the serotonin receptor agonists? So I'm going to have drugs that stimulate 5-HT1 and 5-HT4. 5-HT1 leads to stimulation of nitric oxide, and we've seen nitric oxide before in the motor neurons, the one that are distally, where that leads to relaxation of the smooth muscle tone. And also those drugs would stimulate 5-hydroxytryptamine 4, and those are proximally in the excitatory motor neurons, and this is where acetylcholine release also plays a role. So I hope you understand this interplay or this coordination between 5-HT1 and 5-HT4. Now, those are not the only receptors affected by the receptor agonists, because we don't always have specific agonists. So they could also affect 5-HT3 and 5-HT3. We talked about it, and we talked about its role in the brain. Side effects, most of them are associated with some serious cardiovascular effects, and hence we have to be careful about that. I don't really know if you remember cisapride. I believe I talked about it in the early pharmacogenetic lecture in the very beginning. Go back to that and you will see the potential for drug-drug interaction with cisapride and the risk of QT prolongation in combination with the macrolides. Just for your curiosity, I don't know if you remember something about that. Okay. So an example of serotonin agonists, we are happy that we have prucalopride that we're going to talk about here as a selective, relatively selective 5-HT4 agonist, and we explained in the earlier slide why is this relevant, and by enhancing cholinergic transmission. When is it indicated? Well, it's mainly indicated when we want to improve the intestinal motility. It has a minimal effect on gastric emptying, so it's not really useful for gastroparesis. And at times we may give it to female patients who have severe chronic constipation where laxatives are not really working. We will see laxatives in the second VOP, but at times, in addition to laxative, you need to enhance the GI motility. Some side effects, again, those are everywhere. So you have nausea, diarrhea, abdominal pain, and headache, and you want to monitor for cardiovascular side effects. Now, next we move to the dopamine antagonist. We talked about the D2 antagonisms as antiemetics centrally, but here we're really talking about the D2 receptors and the GI tracts. So what happens in the GI tract? The activation of the D2 receptor would suppress acetylcholine release from the enteric motor neurons, and this leads to reduction in the lower esophageal sphincter tone and reduction of the intragastric pressure. So basically relaxation, right? And hence you would expect that if we give dopaminergic antagonists, that would inhibit the above effect, and that would lead to increased GI motility. And hence this is why, in addition to them being antiemetics, as we discussed before, they can also be prokinetic. Let's move forward. I already mentioned metoclopramide as a benzamide, and that was pramperon as an antiemetic in the beginning, and I did not really dwell much into its mechanism of action because we were not ready at the time. Now I think we are ready to dwell a little bit more. So we already talked that it has an antiemetic effect because of the D2 antagonism. At the time, I did not mention that it also has some 5-HT3 antagonism. And now we see that these antidopaminergic drugs are really quite complex, and they not only affect the D2 receptors, they might affect the serotonin receptors, as we have seen, and it really depends on what receptor we are talking about. And in here, for 5-HT3, we have the antiemetic effect. Fine. Also, I previously mentioned that it has a prokinetic effect. Now we are ready to discuss why. Well, because of the GI D2 antagonism that we mentioned, and that would lead to possible sensitization of the M receptors on the smooth muscle cells. In addition, there is 5-HT4 receptor agonism, and we talked about that when we were talking about the serotonin agonists as useful drugs as prokinetics. So it's a complex mechanism, and in conclusion, it has both antiemetic and prokinetic. The nice thing about it, you would expect a coordinated contraction and hence increasing the transit of the food. It does not really have a significant effect on the colonic motility. We said that this works with the esophageal sphincter and the upper GI. When do we use it? We can use it for gastroparesis. For example, we mentioned gastroparesis before in people who have diabetes and hence autonomic neuropathy. Also, at times we can use it before some procedures. For example, if you want to do an endoscopy, upper endoscopy, you want to put a scope and look at the stomach, for instance, and you want the patient to get rid of the food, right? Because you want a clean stomach. So you may use it as an adjunct before. Also, if you want to do some contrast imaging, for instance, the patient would drink something, a contrast material, and I believe you're going to see some of that in the radiology lecture. And before you do that, you want to also again get rid of the food, and also you want the contrast to distribute nicely in the GI tract. This may ameliorate not only this motility but also nausea. Right, so it has this nice dual effect. Some side effects, we already talked about the D2 antagonism centrally. We already talked about the extra pyramidal side effects such as Parkinsonism, and I believe I did not mention that those can be reversible. So some of the extrapyramidal side effects would be irreversible. So you don't want to give such drugs on a chronic basis, and you want to be careful in children who are at a higher risk of developing the extrapyramidal side effects. So if a patient has GERD, gastroesophageal reflux disorder, maybe those would help. However, you don't want to use them chronically because there's a risk of extrapyramidal side effects. And this is something that I have not mentioned before. This is a problem that happens with D2 antagonism centrally, because dopamine release actually inhibits the pituitary gland from secreting prolactin. Okay, and what does prolactin do? It leads to galactorrhea and gynecomastia. Gynecomastia means increased size of the breast. Galactorrhea, you would have secretion of milk from the breast, and that could happen also in men. Amenorrhea, you do not have your period anymore, and impotence. So those drugs, again, you will see them in psychiatry, but this problem, when you would have increased prolactin release from the pituitary, because of inhibiting dopamine, you would have those side effects, and at times patients would stop those drugs because of the side effects. Imagine a gentleman who has schizophrenia, psychosis, receiving D2 antagonism and develops impotence. What could happen? This patient may stop the drug. Anyway, this is not about psychiatry. This is again, here we are in the GI tract. We're talking about anti-emesis and prokinetic drugs. But again, keep that in mind just in case somebody uses on a chronic basis. Somebody who has gastroparesis and uses it for a long time. Or if somebody has nausea and vomiting because of chemotherapy and uses it for a long time, those side effects may be problematic. Now, another drug is domperidone, and this drug only antagonizes D2 receptors, so not like pramperon that leads to activation of some serotonin receptors, inhibition of others, etc. Not that complex. So here only D2 receptors, and the nice thing about it is that it does not cross the blood-brain barrier. So we do not have extrapyramidal side effects, but it would still affect prolactin release. Why? Because this is on the pituitary, which is obviously outside of the blood-brain barrier. No meaningful effect on the lower GI tract, so we are still at the upper tract. No more indicated for children because there's a risk of cardiotoxicity, and also more cardiotoxicity in elderly patients, especially at high doses. I put the box here again because I'm sure you've heard of Motilium, and I'm sure maybe one of you or somebody received Motilium before for vomiting, and although it is not an antiemetic per se, it is a prokinetic. So if somebody has vomiting, by just being prokinetic, this might decrease vomiting as well. You know, those things could be related. And I believe this is the last slide. So we talked about prokinetic drugs. We started with the serotonin agonist, then we moved to the dopamine antagonist, and finally we have macrolides as antimicrobials. Who are these? Such as erythromycin, clarithromycin, etc. And how do they work? They really stimulate the motilin receptors, and I mentioned that, and I specifically told you, remember motilin because it's gonna come back to us, and here it is. And as a matter of fact, if we take high doses of macrolides, they may lead to very painful cramps, and that is because of this prokinetic effect. They're quite useful in patients with diabetic gastroparesis. They may result in dumping of relatively undigested food, and this is good. What do I mean? So if somebody has a lot of food in the stomach, and this is relevant for people who are, for example, admitted in the hospital, and they have a nasogastric tube, an NG tube, because they are comatose, they are not very aware, so they have this NG tube because they cannot eat. And if you have too much food in the stomach, sometimes some of it will go up and be aspirated into the lungs, and this leads to aspiration pneumonia, which is problematic. So one way to prevent that is to use macrolides, not because they are antimicrobials, but to dump the food into the small bowel so that we do not have this aspiration pneumonia that is associated with prolonged tube feeding in the hospital. One problem is that we have a rapid development of tolerance, which limits its use. And of course, the concerns, some of them you already know about. Ototoxicity, I don't think I mentioned that in the antimicrobials because you cannot mention everything, but it can actually happen with the macrolides. Supranomembranous colitis, obviously those are macrolides. You will always have the risk of super infections, resistant bacteria, QT prolongation, we talked about that. Some macrolides are associated with CYP interactions, etc.